Hi, my name is Dr. Don Buford. I'm down at Texas Orthobiologics in Dallas, Texas, and you can find us at texasorthobiologics.com. I thought what I'd do with this little 5 or 6 slide presentation is go over some questions that have come up over the last couple of weeks on frozen shoulder treatment and how specifically do we do the manipulation under anesthesia. We do the manipulation under anesthesia when the patient's initial presentation is such that they've already lost significant amount of passive motion, or we've gone through multiple non-surgical and non-operative measures, and they still have not improved. And these would be things like an in-office hydrodilation, even an in-office manipulation, and the patient still has not improved. So now we're at the point where we can do a manipulation under anesthesia. This is a gentle technique. It takes all of maybe 5 minutes. You can usually physically feel the joint capsule tearing and releasing. And then at the end of that procedure, I typically inject some salt water for volume and a little bit of steroid to prevent a rebound inflammatory reaction. Let's go through it briefly. This is what the Mayo stand looks like. You can see that we have one syringe with 20 cc's of normal saline, plus maybe a half a cc of low-dose steroid for the glenohumeral joint injection. This is used at the end of the manipulation. You can also see a syringe with 0.25% Marcaine, which I use to do a suprascapular nerve block anteriorly, just medial to the coracoid. You'd be surprised, and patients are often wondering what their pain is going to be like after this procedure. And usually the patients are actually in less pain after the procedure, after this joint capsule is released. I typically do these at the surgery center where we can have control. We use propofol, we use our laryngeal mask anesthesia. Patients are in the lateral decubitus position. And other than the suprascapular block, we do not do any other scalene blocks or anything else. So how do you make $1 million doing shoulder MUAs? Well, here's how you do it. Average reimbursement is about $345. So if you are really doing this to pad your 401k, you can do just under 3,000 shoulder manipulations, and that will get you to $1 million. So that's roughly 7 or 8 a day, every day for a whole year, including Saturday and Sunday, and that'll get you there. If you add an abduction brace, an abduction sling, that'll add about $470 to your payment, making your total reimbursement just over $800. And in that case, you can now drop your MUAs that you need to do to make your $1 million to $1,227. So obviously this is tongue in cheek. This is not a procedure that any of us do because of compensation. We do this because the patient needs it to get better.
Here, I just want to show you our beginning motion. We always test our patients when we're suspicious of a frozen shoulder in the supine position because that allows the scapula to not move, and we can get a true measure of their glenohumeral joint motion. So here with their elbow up at shoulder level, when they try and go in supine external rotation, you can see that that's 0. She's getting maybe 10, 15 degrees, not very much. And there's a hard stop there. So this is a passive block. Supine internal rotation is no better. Maybe 15, 20 degrees of supine internal rotation. So that's where we're starting. We're doing the manipulation now. With my left hand, I'm stabilizing her scapula because we don't want any scapulothoracic motion. I'm going to slowly bring her arm up. And as I do this, I can actually physically feel the capsule release, really kind of micro tearing. And you can see how already we've got her basically full forward flexion. As I bring the elbow down, you can see that now if she were supine, this would be external rotation of 90 degrees. Remember, we started at about 10 degrees. And now in the internal rotation position, this is a little bit tighter. And again, we want to avoid any torsion on the humerus. You don't want any spiral fractions. Never had one, we sure don't want it. We're trying to just hold the scapula in position. That's certainly better than before. So remember that actively, most patients will keep about half of what they're lacking on the day of the manipulation. So the main thing is we want to release the capsule. We're now going to do a little bit of a suprascapular nerve block anteriorly, just medial to the coracoid, which will be just medial to my finger here. And then we'll do a bit of a glenohumeral joint injection for a little bit of volume, and that's done with normal saline and just a very, very small drop of steroid. Thanks.
All right, and so that's the procedure. Thanks a lot.